Hello, my name is Carol Robertson, and I'm going to be talking about documentation. Every service definition, whether state funded or Medicaid, has details regarding what should be included in a service note, including staff qualifications, training, and eligibility for the service. All of this should be reflected in the medical record. A service note is the heart of a clinical record. It is the only evidence you have to indicate that the service provided as you build. It is a legal record that you have to indicate you provided the services outlined in the definition and the policy. It's used for sharing information, coordination of care, summarizes the individual's response to treatment, and it serves as a planning tool. If you're going to use abbreviations when documenting, you need to have a policy procedure relating to that and a list of accepted abbreviations that will be allowed. Only items from this list may be used when entering information into the medical record. Some documentation items to avoid. That is the appearance of cutting and pasting, information from a previous note or plan, information that is not factual, information that identifies other consumers, or altering a service record in any way without following procedures. These are examples of things will end up in a program integrity referral, a plan of correction, or a referral for a network sanction, which could be termination of a contract. Altering the service record, such as using whiteout, is not allowed. An initial strike-through is the appropriate way to make a change or add an addendum to the note. Addendums, however, must be signed and dated just as the note is. The required components of a service note are listed before you. The name of the individual receiving the service, the medical record number, the Medicaid ID number, if appropriate, must appear on every page. The remainder of the content includes a full date of service, month, date, year, the name of the service, the type of contact made, whether face-to-face or phone call, the place of service, and the purpose of the contact. The purpose is tied to the PCP or the treatment plan. A description of the intervention, including time spent and the results. This must be a description of active engagement of the individual and must relate back to the plan. It must also reflect time billed. The total time spent must be included. Different services have different requirements, which will be discussed later. The effectiveness of the intervention or progress toward the goals needs to be individualized to that consumer and that consumer's goals. Lastly, the note must be signed. For licensed staff, use your name and licensure or certification. For non-licensed staff, your name, degree, and professional status, such as QP, AP, etc. For paraprofessionals, handwritten signature and position. Unless using electronic records, signatures must be handwritten. Corrections to a medical record or changes can be done at any time when appropriate, but should be done within 7 days for billing purposes. Electronic record changes must be made by the person who made the initial entry and must be signed and dated. Do not delete the original text, but do explain your error. Paper record correction should also be made by the person who made the initial documentation and should be recorded legibly above the initial entry. Correction should be dated and initialed with an explanation of the correction also, and correction fluid or tape should never be used. There are lots of different types of notes. You have them before you. I'm not going to go in detail on each one. There are shift notes. There are group therapy, and remember when writing group therapy notes, they must have an individual response that relates to the individual's goals. Team services, if one person writes the note and others involved, the note must include the participation by others. Periodic services are those services that are provided on an episodic basis through short recurring visits. Documentation frequency is per event. Day-night service is provided regularly in a structured environment. Is offered for a period of 3 or more hours or more within a 24-hour period. It needs a full service note. Times for notes may vary. For example, SAIOP, day treatment, or partial hospital would be written on per date of service. PSR, written weekly. ADVP, quarterly. These services can be billed in 15-minute increments. However, the notes must show the total amount of time. Time can be indicated in attendance sheets or included in the note. A 24-hour service means 24 continuous hours. A full service note for the entire time is required. A notation here for the purposes of this webinar: Level 2 family type falls into a 24-hour category. However, they can use a grid instead of a full note. Requirements continued: the name of the individual, the record number. This I went over in the previous slide, but just to reiterate, goals must be addressed, a key relating to a specific goal with interventions and assessments and progress toward goals, the duration, and the time. An example of a grid, a grid looks like this. This is a good example of a grid. It gives each one of the specific things I just referenced, and you have space to record. Service-specific requirements. Each of the individual services have just a little bit of a different twist. For example, ambulatory detox must have a documented discharge that has been discussed and filed in the record. Day treatment, the PCP has to include transition plan with progress made. Residential level 2 must include critical events, interventions, specialized therapy such as sex offender therapy if needed. ADATC detox, crisis stabilization, and non-medical detoxification services need to include the rating scale tables, the withdrawal assessments, and the flow sheets. As with other services, a documented discharge plan should be included in the record. Opioid treatment, you've got to have the daily dosage record, including a record of all the home doses prepared. Social setting detox, I'm not going to read those to you, but they're listed there for you. Discharge planning and referral to a treatment or rehab center. Facility must complete a discharge plan for each client, and you have the reference to the administrative code listed for the complete language. Other service-specific requirements: SACOT, substance abuse medically monitored community residential treatment. Again, must have a discharge plan. Substance abuse non-medically monitored community residential treatment. The programs for women and children shall provide documentation of all services provided to the children in the program. The PCP goals for the parent-child interaction, progress toward meeting these goals along with a discharge plan must be in the record. Halfway house, full service note for each day. Modified record. This is a record which has a little bit different requirements from typical. For the purpose of this training, there's one service that will require a modified record, and that is behavioral health prevention, education services for children and adolescents in selected and indicated populations. This is found in Chapter 11 in the Service Records Manual. It's one that not many people are familiar with, but you need to make yourself aware of. The Service Record Manual is being revised. When the new manual comes out on October 1st, it will be Chapter 10, not Chapter 11. Just a little bit more about what's required there is it's primarily about assessments, and I've listed the items that you will need to include in your assessment. Most of them deal with risk factors. Okay, this continues on with what you need to include in the assessment, current abuse, current use, any relevant histories, mental status, anything you need to rule out other conditions. Then when we look at the service plan for this service, it's based on identification of the child, adolescent, or family problems, needs, and risk factors, including strengths, supports, and protective factors. It must match the profile with the appropriate evidence-based practice and signed by the participant, parent, and LRP. Following the delivery of service, the minimum standard for documentation is the grid. Additional factors that you will need to include in the grid is which evidence-based practice you're using, and the identification of the model or goal, the activity description, and the signatures with changes in status. Now let's talk about late entries. All notes are to be documented within 24 hours of completion of the service. Anything after that 24 hours should be indicated as late. Only notes indicated as late from day 2 through 7 can be billed. Notes after the 8th, on or after the 8th day cannot be billed. Notes that are late but not indicated as late will not be accepted on monitoring visits or audits. This slide just gives you the time frame for other types of services. Same here, late entries for 24-hour services. Okay, for monthly notes. All entries made after the time period must be marked as late, include the date of documentation and the date of the service covered, signed and dated by the writer. If electronic records are used, the entries are tracked and stamped by the system. You do not have to follow the step I just referenced. However, a warning. If you type something into a computer and save it, it is not an electronic record. Only approved electronic records are allowed to skip this last step. And you really need to pay attention to that, because a lot of people assume that anything typed in a computer is an electronic record. This is a grid that just gives you a timeline for when notes are late, when you can bill and when you can't bill. Okay, let's talk a little bit more about signatures. All entries must be signed and dated. Each signature must contain the appropriate credentials, degrees, licensure, title of the person entering the information. If it's an electronic signature, the provider should be given the opportunity to review. For professional signature with credentials, degree, or licensure at the convention, and for the licensed professional, that includes an LCSW, LPC, LPA, etc. For non-licensed professionals, you need the full signature. Once the entry has been signed electronically, the system will prevent it from being deleted or altered. If errors are found, an addendum should be added. Passwords and/or other personal identifiers should be used and changed at intervals. An electronic signature is under the sole control of the person using it. It cannot be delegated to another person. You as a provider should have policies and procedures to safeguard against unauthorized use of electronic signatures. What staff should do if application for documentation is unavailable. A list of staff who are authorized to use the electronic signatures, and your governing body should authorize this. Let's change hats a little bit and talk about consents. An informed consent is required in many situations, such as the release of information, consent for treatment, and re-release of information. The consent to release substance abuse information is even more restrictive due to federal requirements. NCAC 27D0303 defines what consent is. This slide has just paraphrased that information. It is not intended to be word for word of the rule. Just things to be aware of, be informed of the procedures that are to be followed if your consumer chooses to withdraw a consent. Consent always must be in writing and documented in the record. A minor can give consent to a physician for prevention, diagnosis, and treatment of venereal disease, pregnancy, abuse of controlled substances or alcohol, and emotional disturbances. The next couple of slides list the required elements of a consent. And I caution you, specific name or a general designation of a program or person permitted to make disclosure. A signed blank consent form doesn't mean anything. The name or title of the individual or name of the organization to which the disclosure is to be made. Further on down the list, name, purpose of the disclosure, how much you're going to disclose, signatures, date, when it expires, when it's no longer necessary, what's the purpose it was given for, and again, blanks on this form mean nothing. A statement that consent is subject to revocation at any time except to the extent that the program or person which is to make the disclosure has already acted in reliance upon it. In reliance upon it simply means that you provide treatment while you're waiting for consent to be signed. For first consumers, there must be a signed release of information between the individual's county DSS and the provider to communicate regarding the assessment and disposition. Caution here, when you are doing the consent form for a county DSS or a school or any county office, you must list the name of the county. You cannot just do generically DSS. Redisclosure. This comes from a federal requirement. CFR is the Code of Federal Regulations. That's the site. And it talks about when you can redisclose information. Again, have to have the consent. A general authorization for the release of medical information or other information is not sufficient. Federal rules restrict any use of the information to criminally investigate or to prosecute any alcohol or drug abuse patient. And I've listed here the consent form with just cautions. Everything that's on the form on the next two slides and the red indicates you cannot leave it blank. Okay. Just to recap, these slides have reviewed a lot of information you've been given before. However, these are items that continue to show up in audits both internally and externally. I hope you will keep these reminders close and refer to them if you're not sure about something. I also hope you will share with your coworkers who are not attending this webinar. Thank you for your time and attention. Before we go, do you have